Hi, my name is Maria Nazarova, and I am a neurologist by training and a neuroscientist, and I'm interested in upper limb motor rehabilitation and recovery I have been interested in that for at least 15 years, I think, since in the time I studied my PhD, and I'm still trying to understand it. And today I want to share with you a bit what we already know about this and what we are trying to learn about this. And just to give you a background of my current work, I'm currently a researcher at Aalto University, and we are running a project, including a clinical study, where we are trying to understand how we can guide brain rehabilitation using information about the brain. So the project is called Brain-Informed. But today I'll try to cover upper limb rehab in general and also answer a bit to the question that were sent. And let's see how it goes. Okay, so what do we know about upper limb motor recovery after stroke? Let's go through the agenda, how I will try to present it. So first, we'll talk a bit what is stroke, what does it actually mean? Then we'll go to motor impairment, which can happen and usually happens after stroke. Then we'll look at current directions and future directions for upper limb motor recovery. Then we'll go specifically in a question of motor recovery timeline and the importance of repetition. And I can already say that the repetitions are very, very important for rehabilitation. And then we'll go a bit towards the brain, because stroke is something that happens in the brain, and we'll talk how brain and movement are connected, how we can use brain to predict the recovery, and then we touch our current topic, how therapy can be guided using the information about the brain. And then we just go very briefly into questions and answer section. I just want to say from the very beginning that the whole webinar is just informational, so it should not be considered as medical advice. So what is stroke? Stroke primarily is a very, very common situation, very common disease, and it will happen in 1 out of 4 if we talk about adult people, and this is the data of World Stroke Organization. So if you have a stroke, you know that you're not alone. It's a very common situation. There are many people out there who suffered the same disease. And if we talk about stroke, we need to understand that stroke starts from the vessel. So it's actually about the vessel when it's starting, but then it goes to the brain. And everything that people experience after stroke is already about the brain. What is stroke? Very much depends on which vessel is involved. So there are many vessels which are feeding our brain, and depending where the problem was, it can be one or the more vessels which is blocked, then the stroke can look very different. This is just a very, very simplified vision. So depending on the area, or some people can experience problem with a face and arm and hand movement and speech. Others will experience, depending on the vessel which was involved, problems with walking and leg weakness, and also behavioral things. And people who had stroke here, more towards occipital area, will have problems with vision, etc. And where I don't even cover now big part of the brain, which is called stem and cerebellum, and it will provide, for example, cerebellum coordination problems, but not only, also cognitive problems, and stem can provide different problems as well. So it really depends where stroke hit. And actually, the treatment of stroke now changed very much even during my lifetime or being in the area. It changed dramatically in terms of the acute treatment. So now acute stroke can be considered as treatable disease. So here we see the situation when the vessel is blocked, and here this vessel was reopened. It's called revascularization. So the vessel was reopened, so there is a chance that the brain was not really suffering in this case, or like not suffered that much. But the problem is that still quite a small percent of people are really eligible to revascularization. So what do we have in the end? We have the situation that stroke is still #1 cause of disability, at least in Europe. And still lots and lots of people are left with stroke consequences. And those consequences, again, they are very much dependent on which vessel was involved and then which brain area was involved. It can be different, including cognitive impairment, problem with swallowing, problem with mood, epilepsy, problem with speech, pain, big problem is fatigue. But now we'll be talking about the most common problem, and most common problem in stroke is actually motor impairment. And yeah, it looks like that. It's a view of motor impairment, which is known for several centuries, quite well known for doctors, but we are still working on what can we do with this. So this is a general situation, the motor disability. It can be also called, maybe you heard the term hemiparesis, but the most common and something that actually stays with lots of patients after a year or after a year of their stroke event is the hand and arm problems. And hand and arm problems affect around 2/3 of stroke survivors. So it's a really, really big and common cause of disability. And actually, we can look at this motor impairment, upper limb motor impairment, and hemi is just half. So it's like part of the body, half of the body is in problem. But we can look at it, and now it's kind of a new way of looking at it, categorizing it into special subcomponents and trying to understand special subcomponents separately, maybe working on them separately, and also trying to understand, and I'll go for there a bit later, but we're also trying to understand how these different subcomponents are connected with the problems in the brain. So you can think about your hand, and there are different things. It's like arm dexterity or proximal dexterity is ability to reach for concrete goals. But if one have not enough strength, we can't even see it, but it's a separate thing. So there is a strength, arm strength, proximal upper limb strength, but there is also dexterity, reaching dexterity of the shoulder, of the arm. There is hand dexterity, and I mean, it's a very complicated term, but you can think about finger individuation and your ability to do movements like that and to grasp small objects, but there is also hand strength. And some stroke survivors can have quite good hand strength, but still struggle with the hand dexterity. And there are also those problems which sometimes are mostly seen when we are in rest. So sometimes we don't even know whether they are important when you move, but you can think about them as additional movements that a person doesn't want. So spasticity is like higher tonus when muscles are more contracted when we don't want them to be. And synergies, pathological synergies, when a person wants to do one movement and many movements are happening at the same time so all these involuntary movements, there would be called pathological signatures. So why it's important? Here is an example when we talk about arm strength and arm dexterity. So if you try to move your, if you try to reach for a goal somewhere, if you are getting to the, let's say, if you are trying to get a yogurt from your fridge, you need to reach for that. If you don't have enough strength, you would not be able to do it. But we can see, just using a very simple thing like, anti-gravitational support, and it's quite widely used for stroke rehabilitation. Maybe you have used it, and it's a very useful thing to have at home, for example. You can apparently do some reaching, and now it's also studied. So here is basically the same construction, but in a much fancier way in a robot. And here is a person without a stroke, and here is a person with a mild paresis, mild problems, and here is a person who is trying to use his or her affected arm, but with a moderate paresis. But you see, if you are just trying to, so you're sitting here in the in the center, and then you are trying to reach, like for a, it's like flower. So you're trying to reach towards different goals. You can still do it even with a moderate paresis if you are taking away this load. So if you don't care at the moment about the strength of your arm that much, but yes, it's evidently worse, but you can train it in this way and you can study it in this way. So it's really important. And another thing, now it's kind of a hypothesis still, but we know that if we look here, we're looking at strength development in the hand and finger individuation development. And see, basically, now it's a hypothesis which has some data for that. We're also working in a similar direction. So you can increase strength and get some individuation, but if you want to get towards the original level of finger individuation and your original level of hand dexterity, it's a separate thing. It's independent of the strengths, and it should be trained separately, independently. Another thing is that usually if one hand is affected, we are prone to use the other hand. And actually, and it's known for, again, many, many years. This is the studies from middle of the century, but it was actually known, basically 19th century, that people kind of learn not to use the affected hand. So here is their affected hand, which is just laying here, and the person is reaching for a cup using the non-affected limb. So half of stroke survivors don't really use their paretic hand in daily activities, even though they had capabilities to do it. So if they are reminded to do it, there is a chance to do that. But we're just learning. We're still working on trying to understand why it's happening, but we know that it's happening in half of stroke survivors. So this is something to think about. And we can think about it partly as a compensation. So in motor impairment, and maybe you heard this term, motor compensation is something that lots of therapists are working a lot. This reaching using unaffected hand is just one of the examples, but there are many others. So here is, for example, something which is called proximal non-use. So even if you can reach with your affected hand, you tend to do immediately with the trunk, and you need to be reminded, you need to be constrained to actually use the arm which is able to do it. And yeah, there are assisted movements when you help with your unaffected hand, your affected hand, and there is this additional movement of the shoulder and the trunk. So we're still trying to understand how to deal with the compensations, but this is something just to have in mind that it's something worth noting and thinking about it. So sometimes we can learn the original pattern of movement, and sometimes the movement can be reached only through compensation. This is something to work together with a physical therapist and occupational therapist to decide in a one concrete case. So if we move to what can be done, what are the current and coming directions for upper limb motor recovery therapy? So there are those which are really ready and widely used for broad clinical application, and those are physical therapy and occupational therapy, and or there are some there is kind of a gray zone. So in different countries it can be that, let's say in Finland, it seems that mostly occupational therapists are working primarily with the upper limbs and physical therapists are working primarily with the lower limb, but actually both categories of medical specialists are interested in helping with the upper limb. And this is something that we know it's working. That's a proved methods, but we still don't know which approaches are better than others. We just know that therapy works. Then there are special types, basically, of physical and occupational therapy, mostly physical therapy. It's a mirror therapy, and I'll touch it a bit. When you just use a reflective surface, it can be mirror, something similar to mirror, or use it for recovery. There is constraint-induced movement therapy when unaffected hands, so it can work for those who can do something with their affected hand, like to some extent. So it doesn't work for really severely affected people. And there are many others. So brain stimulation is now kind of moving here. So you see here is basically the scale where we are going like this with the ready for broad clinical application that you can see in clinics. There are those which are already in clinical, like very active clinical trials. So you can get them if you are participating in trials, and sometimes in some places they're available. And those are just like getting into clinical trials, and they're already in clinical trials, but not that like that big ones. And those are preclinical development. So now this is they're scaled from basically 8 years ago. So now it's moving a bit to the right to ready a phase for broad clinical application, but basically the picture is the same. So we have also virtual reality and games. It's a fast development area. And we have approaches like brain stimulation, and I touch it a bit. Even those really need a big conversation by themselves. So let's start with one of the most proven physical therapy, and this is called constraint-induced therapy or constraint-induced motor therapy. And here's basically a very nice illustration. So the unaffected hand is constrained. There are many ways how you can do it, and the other hand is just kind of engaged in all the activities. So it's proven that it works. At the same time, how does it work? Actually, people use their hands. So it's really working, again, this learn and use very much, but it's not specifically doing, it doesn't necessarily change in the pattern of movements, but it's really working in terms of like you start using your affected hand more. But evidently, it doesn't work for everybody. So not everybody will be able to do the movements. You need to have some level of activity already that will allow to go there. And this is something to discuss individually with your physical therapist and occupational therapist. There is mirror therapy, and I used to use it a lot, and this is I personally really like this type of therapy, and it's also a proven one. But you need to know that it actually was invented for people without a second hand, for people with phantom pain, people who will move their, let's say, or the hand that they still have, and the other hand in the mirror will be moving in exactly same time. And that's actually a crucial thing. So in stroke, it doesn't necessarily doing the same, because if you have the other hand which is affected and is trying to move slowly, it will move with a different speed than the moving hand. And here it's important to think about this timing. So here we're already getting into the importance, and I believe in this importance, to stroke survivors themselves think about what's going on in the brain. So we are getting into importance of the brain, because if you do, I call it here mirror therapy, but maybe you should actually say it mirror illusion, because you can do it like here. I'm touching fingers of a colleague, of a volunteer who is also a colleague, or you can experience this mirror illusion, or in any situation you can do it at home with any of your relatives and friends. And we know that this mirror illusion has a very clear signal in the brain. So when we do bilateral movements, synchronous, we have an activation in the brain in one very concrete time. So it's a concrete time, which is, the time specificity here is less than half of a second. When we don't do any mirror movements, there is no activation and no bilateral movement, just one finger is moving, or one hemisphere is activating, the other hemisphere is not. But when we do mirror, you have a very concrete time when something is happening in the brain. So it's really important, this concrete synchronization. And this is something to think about when you do mirror therapy. And there are many ways of brain stimulation. So there are those which are kind of now even considered conventional, even it's very far from being conventional, but they are at least quite widely available. Those are transcranial magnetic stimulation and transcranial direct current stimulation. So both of these methods, they can influence the brain and change the state of the brain, either quite locally in terms of TMS, less locally in terms of transcranial direct current stimulation. They're both non-invasive, but we're still working on understanding what they are doing. And there are now new types of nervous system stimulation. So apart from this TMS and TDCS, we now have vagus nerve stimulation. It can be invasive, but it can be also non-invasive, and there are studies showing that it may help for some patients. And there are also quite a lot of research in terms of invasive brain stimulation. So this is one of the most recent interesting approach for the cerebellar stimulation. It's not actually for patients who have cerebellar stroke. It's just modulation for the brain through cerebellum. But it's really a big topic. It was a separate conversation. But let me just introduce you to one thought to have in mind about the brain stimulation. That's a thing that we need to think what to stimulate. And let me just bring you one example about the TMS and TDCS approaches that were used for quite a while, more than 10 years. So there is a hypothesis, and there is an illustration of this hypothesis, that two hemispheres are interacting in a different way after stroke. So if one has an affected hemisphere and a hemisphere where the lesion, the stroke happened, there is another hemisphere, which we call unaffected or contralesional, but I mean, it's definitely in the same brain. And it was shown in some patients that this so-called unaffected hemisphere is actually it can be a bad guy. So it can inhibit the affected one. And in this case, and this is actually the background for the majority of types of stimulation in the brain, you need to inhibit this unaffected hemisphere. I mean, it used to be that way, but after that, there were new research like findings which showed that in other patients, most probably in patients with more severe problem, the unaffected, this contralesional hemisphere, which doesn't have a stroke lesion, it's actually the only guardian angel. That's the only thing that's helping. And in this case, to inhibit it would be kind of strange. You need to activate it. And we're still battling about that, so it's still not clear. So that's very important to think, to have in mind when you think about possibilities for brain stimulation, that it should be individualized. This is the question that you have to have in mind. So yeah, otherwise I'm a big fan of Lewis Carroll, and I think we are in many cases when we talk about the brain stimulation, we are in the situation of Alice. So when Alice came to a fork in the road, she asked Cheshire Cat, which road do I take? So we are asking, what do we need to stimulate? Where should we stimulate? And Cheshire Cat asked, where do you want to go? And because Alice said, I don't know, the answer of the cat was, it doesn't matter. So in many cases, I think we are still there. So that's actually stopping our progress in terms of brain stimulation. And in many other ways, we need to understand what we want to achieve. And I think it's important in the individual level. So I think it's also important to understand if you're a stroke survivor or if you're a relative of a stroke survivor, so you can think about it, what's needed to be achieved in this concrete person. Another type of a stimulation, and there was a question about the functional electrical stimulation. So there are studies about that, and I think in an individualized way, it's a very useful approach. Here I just showing this is a photo of a study which is going on in Germany, in Max Planck Institute. So it's just a clinical study which is combining functional electrical stimulation, but also something which is called brain-computer interface. So when the signals of the brain of intention of moving are transferred into the stimulation, and also, it's combined with the brain stimulation, but we still don't know the result. So this is something it's a hope in that there are active studies, but it's not a solved problem. And also another type of therapy, which I think you can't avoid noticing if you are in this field, if you have to deal with this, it's robots, because it used to be even much more popular. And the idea that the robots can help to increase repetitions, can do things better than therapists. The problem is that content and control of the repetitions matters, and we'll get to repetitions a bit after that. And therapies are also they're always controlling what's going on. So still for robots, we don't have enough proof, at least in the way how robots are doing right now. It was not really changing the ways how we can do in therapy. So still the best thing that we have is to have active work together with a therapist, or using the instruction from the therapist. Let's move to the time part. So we're saying that it's important to do rehabilitation, but does it matter when you're doing this rehabilitation? And it appears that yes, it does matter. So here we have two graphs. Blue one is the plasticity. And the plasticity was, like if we are talking about grown-up people, it was, not that high when we are already older than after we are much after our 20s. But after stroke, the plasticity is increasing very, very, very much. And here is the functional level, what's behaviorally available for a person. So here is the stroke. We have a big drop of what we able to do functionally, and then the functional recovery starts. And you see that the very active plastic period is actually quite short, but the recovery is going forward, and is going forward for years. So it doesn't stop there. But what is this sensitive period? So it's very hard to study it in humans. So researchers found out how to study it in mice. And evidently mice, if we talk especially about the upper limb, they don't have such flexible fingers as we do. But you can actually train them. If you give them the pellets of food and they need to reach for that, you have to train them. You can train them. And if you train them here, this is a mouse which was trained to use this reaching movement to get her food. And then researchers made a stroke. So they actually do an artificial stroke in the mouse. But right after the first day, they start training the mouse again. And the mouse is getting back. So you here just to have the how many successful pellets of food the mouse was able to reach. So the mouse was getting to its original level and maybe even a bit higher. But what's going on if we wait? So here was the stroke. Mouse already learned how to deal with this reaching movement, and it had a stroke, artificial stroke, which researchers did for it. But then they didn't do anything. They didn't train it. They waited for a week. And then they start training. And mouse was improving a bit, but not to the original level. But then they did kind of a crazy thing. They did a stroke. They provided the second stroke in a very nearby area. Very nearby. So here was the stroke in the motor cortex, and here was the stroke which was right before it, right in front of it. It's called premotor cortex. And they started training immediately. And the mouse was able to, it was even worse after this for sure, but it was able to get back. So this is something which is called sensitive period reopening. And there is now a hope, and lots of research is going about, can we reopen this sensitive period in humans as well? Giving a second stroke is definitely not an option. So can we do it? So there are still research, and there are hopes for brain stimulation. There are hopes for drugs. So for example, in some clinics, they give fluoxetine. It's actually an antidepressant drug, but they give it for everybody who doesn't have contraindications, because there were studies in some clinical studies, not only rodents for sure, which show that fluoxetine can also reopen this sensitive period. But this is now only ongoing research, but people are working on it. So there is hope for that. And why it's important, this sensitive period, is because, how system is working now, we already kind of, discovered that the system is treating stroke primarily as an acute disease, which is not true, is chronic, but also in the beginning, in the hospital, the main thing is to get people able, to more help people sit, to help people start walking. And only after a couple of months, the hand problem is realized. And that's a problem of this sensitive period. So it's very important to think about it. I mean, like, if there is a secondary stroke, if you know about stroke, and you can recommend somebody to work on the hand quite fast. But there is also this hope to reopen the sensitive period. So I really hope that this will be a research that will bring a big change. And a very good thing is that, yes, this training, sensitivity to the training in this mice, and we have it in humans, it makes sense. It's really a problem. This is our conventional. So here is the therapy in humans. This is just a conventional therapy several times per week. And really, people in subacute period in stroke, they improving. There is just a scale of improvement. So like, 0, it's how it started, and or 20 is really big improvement already. 5, 6 is clinically significant. So it's something that you will see functionally, or will see improvement if we train subacute or people, so 2 months, 1 month after stroke. But if we get the same amount of treatment for people who are in a chronic stroke after 6 months, or like after a year, or beyond 4 years, it doesn't really help if you train with this conventional amount of therapy. But if you train people really intensely, if it's active repetitions, and this actually about like at least 90 hours. So it's really intense training, the level of training that professional athletes, or like very serious, not hobby group, but like very serious competitive groups or competitive young athletes, like kids who are doing 4 times per week, 5 times per week for 3 hours, 4 hours, really intense training. So this intensive training, it's actually paying off. Even in people after 4 years, and in all this like chronic stroke survivors, it works. So we know, and I mean, it was known by all the like lots of relatives and therapists, but it was not really, and it's still not really kind of considered in the system. But we know, we have a very clear proof that intensive training pays off. But if you do conventional therapy a couple of times per week and you don't do anything else, it works in subacute period or even earlier, but it doesn't work later. It doesn't help if you don't do anything. You need to train very intensely. So how can we do it? How we can get this elite athlete repetition level? That's a big question. I think it's one of the key questions in therapy, but I mean, it's also an individual question for everybody. And that's also something that we know for now more than 100 years, that when you do repetitions, these repetitions differ. Our movement is repetition without repetition. And this is, I mean, like it's in very old works, which were, and after that, it were so many replications of that. So if you have a professional, it can be, or a professional who is targeting this goal. So that targeting the end goal would be very precise. But the movement around, the more professional person is, they would be there, like it would be very free. And if you see, how people are, I don't know, dancing, like when you're learning something, you are doing very stereotypical, but professionals are very free in whatever is happening around, but very precise in their goals. And this is something to have in mind when we talk about these repetitions. That's something to have in mind when you are training. And yeah, there are some holistic points, but they're very, very important when you think it's, again, it was totally like a separate big conversation. But if you need this level of repetitions, definitely if we are talking about like young athletes, it's easier. And in stroke, we have a fatigue problem. But that's something to have in mind and to deal with this and to discuss with the doctor and with the therapist and deal with the family together. So fatigue can hold you back, but there are ways how to deal with fatigue. Sleep, you have to get enough sleep. That's very, very important. And it's something to think about and to put in your routine. And here is again, it's a separate conversation. And maybe if there are issues with sleep, you can consider it will definitely hold you back for rehab if there are problems. So good nutrition, mental cognitive problems, and support of the environment. It's very important to do it together, and it's very important to support also family members. It's evidently a very huge burden, which is not really realized by many people when they are not there, but it's a clearly huge burden, and we are just here. I can just say that it's very important to understand for us as a community. And yeah, I mean, this is something that therapists are working usually. Now there is this widely used, internationally used international classification of functioning, disability and health, and it's considering all those factors. Say it's not only health condition, it's body function and structure, but also its participation, personal factors, activities, and environmental factors. So this is something that your occupational therapist will work with, but I think it's also important for families to understand those things, because all those things are building this foundation and building this house of successful rehab. And let us move toward the brain part. So we were talking about the practical things and behavioral things and how to dissociate different components of this hand and arm problem. And I just mentioned that, I mean, scientifically, it's very interesting for researchers, but it's very practical as well to try to understand how actually brain problems, because stroke is a brain problem. It starts with the vessel, but then it goes to the brain, how it reflects in the behavior and how we can use it in a practical way for rehab. So how our brain moves out of the body. It's a big, I mean, it's a very huge topic, and motor control is one of the most interesting and difficult part of the whole neuroscience. But in a kind of simplistic way, we can think about the brain part. We have motor cortex. It's over here, and the red part is sometimes, in a practical way, it's called hand knob. It's a knob where, for example, if we stimulate with our transcranial magnetic stimulation or invasively, you'll have a movement of the hand. But it's much wider, these areas which are called sensory motor areas. So they are here in the cortex. Then there are many subcortical structures inside that I don't mention, and there is also cerebellum, which is working as a conductor of everything. But there are many, many components. But if we talk about this very simplistic way, if we talk specifically about the voluntary movements, there is this motor cortex and wider sensory motor areas. And then there are descending tracts, which are going from the cortex down to your spine, to the spinal cord. And if we are talking about the upper limbs, it's going to the cervical part of your spine. And after that, it gives rise to nerves, which are then getting to our muscles and allow our fingers moving. Our fingers don't have any muscles, right? You can touch your fingers and see it doesn't have any muscles. All the finger movements are about the muscles which are over here or even over here. So if I do extension of my fingers, I contract the muscles here. So that's the kind of a general idea, that we have a motor cortex and the descending tract. And those are evidently, if one has a stroke somewhere here, they can be compromised in stroke. So here is the same kind of way, in a bit more anatomical way, just to show that. So corticospinal tract cortica, meaning it starts in the cortex. Spinal means it gets to the spinal cord. It's our biggest highway from the brain to the spinal cord and then eventually to the muscle. The muscle, it would be already the nerve. So that's really important to understand that this is something that we have to move our muscles or in a volunteer way. So when it's a stroke, it's not a problem of the muscle itself. So it's not a problem of the of the hand or arm. It's a problem which is starting centrally. So it does the signal doesn't go properly. And the signal from here, the spinal cord, is still safe in stroke patients. So it's still sending something. So that's why we have, for example, high tonus and high spasticity here as well, or high reflexes. When doctor is checking your reflexes, you can just jump because the spinal cord, these neurons are still very active, but they don't have enough communication from the brain. So this corticospinal tract, it's something very, very long. So here is the brain, and here is the spinal cord, and here are it's the parts of our brain stem. So our brain is basically, it looks like a tree. So it has a stem and it has its branches. So here's our branches and here is the stem. And this corticospinal tract, just imagine it, it's starting here and it's going over here. So it's very, very long. And this is actually, it's one neuron, one cell body, which is going down, and it's still one cell, going right to the spinal cord, to this part, and then communicating to neurons, to motor neurons, which will be sending signal to the muscles. So it's a very fragile thing. It's so long. And if we think about stroke, it's something that can affect it. But if we think about our abilities, this is a very special, very elaborated structure of our nervous system, which is most elaborated in human beings. That's something that's allowing us to play piano or play violin and do very fine jewelry. But at the same time, because it's so long, everything which is so long is quite fragile. It can be damaged at different levels. So here is the MRI of a brain. So it's an image of a brain with the lesion in the cortex. This is something that can be very local in the motor cortex. Here it's still MRI of the brain, but just below, somewhere here. And it's a lesion in the middle of the brain where all these tracts are going. So actually it's a lesion which is which can look very small, but it affects exactly where all these tracks, it's just like highway. So it affects lots of tracks here. And this is the brain stem. So this is the stem of our brain tree, and it also the place where lots of tracks, lots of highways are going. So those lesions are very different, but they all will affect corticospinal tract, and they all will bring uplimb motor deficit that we were talking about. So now we kind of know that a key thing for the uplimb motor deficit in stroke is actually this corticospinal tract damage. It's really, really key. And how we can assess it. So one thing how we can do, and we touched the way of transcranial magnetic stimulation. So it's a method which is non-invasively stimulating the brain. So we stimulate the brain with a magnetic field. It induces electric field in our brain tissue. And if we put it over the area where the motor cortex is, we will excite some of the neurons, and they will send the signal through corticospinal tract from cortex to the spinal cord. And after that, if it was enough of this activation, and if the tract is functional, there will be muscle contraction here. The muscle will contract, the finger may twitch, and you can measure it using different techniques, for example, or we can put the sensors and see the myography signal, so you will see how the muscle is contracting. But this is the way how we can see when the tract is functioning. So if we have a lesion here, we may not have this contraction. It's called multivoc potential. So you will stimulate here, but the response would not go there. So this is the way how we can assess it functionally. And actually, we know that it's working even in a very, very super acute situation. So I was showing in the beginning the situation in the acute stroke. So here the vessel is blocked, and here the vessel is reopened because the team in the acute stroke ward was working on this, and they made this revascularization possible with the drug or with the surgical technique. They reopened this vessel. And in this patient, this was a very small response. I mean, this is just unaffected side. Let's say the stroke was or affecting the left hand. This is the right hand, but in the left hand, there was a very small response. So the tissue, the brain tissue, was not able to excite when it was stimulated. But then when it was the revascularization, when the blood flow was restored, the response was restored. So, and this patient was well after that. But the other patient, even the vessel was reopened as well, but he didn't have the response, and the response didn't come back, and the output was bad. So this is something that's really working in the way that it's showing how functional is the brain, how functional is this corticospinal tract. And can we do something to assess this corticospinal tract in the chronic phase? Yes, we can. So, I mean, you have already seen this picture. So this is just, I mean, it's red just because we are looking where it's typically in people. So it's just kind of a mask where we are overlapping different people. So here is the brain, we're looking at it frontally like that. And here this place where the corticospinal tract going from the cortex down, here is the stem, and then we go down to the spine. And we can look at it in patients, and this is something that I did quite a long time ago in chronic patients, and I was comparing basically how one of the metrics that you were using to assess how the tracks, whether they're going all together or there is a disruption of their ways, how it looks like a different kind of different steps when we go from the cortex down to the stem. And you see that only one line here is different. And this line is actually the most severely affected patients who didn't recover well, so they're chronic patients. And this difference was very local here. So we can see using, this is the method of MRI, we can see a very good association of the recovery with the state of the corticospinal tract. But it's just to see at one concrete point, or the previous thing, the functional thing, you saw it for prediction. So here, just to see that this structural way of assessing and functional way of assessing of this corticospinal tract, they are basically in chronic phase, they are saying basically the same thing. Though it's a reality. This is something we can find in the brain. Can we use it somehow? Can we use it in a practical way? Can we guide therapy using that? So can we say that to a therapist that here is a good connection, here is a bad connection? Can we use it in some way? So we are trying to actually see how we can use it. And again, just think in a very general way. Right now, we can see the visible movements. But there is the whole information about the brain, which you can consider the hidden potential. And that's true. We know that two-stroke survivors, they may show similar movements, but they can have different brain and spinal cord capacity. So this hidden capacity should influence the rehabilitation. This is what we believe. And here is the question, can we use, because we already know, the brain is a very complicated structure, but this corticospinal tract is something that we really know for many years, and both structural and functional integrity is really important for rehabilitation. But can we use it to guide therapy? And one of the ideas that we had is that if we stimulate this hemisphere with a stroke in it, it's called AH, just affected hemisphere. So with the hemisphere with the stroke, it's red here, like with a red thing. Some of the muscles, when you stimulate, will respond, but some will not. And we are trying to see whether this information can actually guide therapy. So we are trying to bring brain information to therapists. This is what we are doing in our study, Brain-Informed. So basically, we are trying to get from here, when therapy is based purely on visible assessment of movement and on therapist intuition. So it's very important, and it will be always important, to rely on a therapist intuition, and it's a big factor, experience of it. But we also try to empower therapists to build clinical decision-making tool to support motor rehabilitation planning and guidance using this brain to muscle connection information. So that's, again, I think we have seen this in some way, right, for the corticospinal tract, which is starting from the motor cortex, it's going through the brainstem, it's getting to the spinal cord, and then there are connections with different muscles. And we know that in one muscle it can be a good connection, and in the other it will be different. It means that it's not like, corticospinal tract is not one way. It's like many, many, many streams in one big flow. And we're trying to see whether this information, because we know that this brain muscle connectivity is different for different people, we are trying to see whether it can be meaningful for therapy. So basically, we're trying to build the first brain-guided therapy. So how it used to be, we can think about guidance and prognosis of therapy and visible movements and information from the brain. So guidance, how it's done now, we look at the visible movements and we decide about the therapy. You've seen that we can actually predict, we can talk about prognosis based on the brain-related information, the functional state of the corticospinal tract, for example, and talk about the prognosis. And there is also one thing that I haven't mentioned, but we know that the best predictor of the recovery is actually the behavioral level that people have in the very beginning. It's called proportional recovery rule. So we can predict how a person will be doing just based on the fact how he is doing in the beginning of stroke. But we want to bring brain-related information into rehab therapy guidance as well. Right now, we're just starting a study. So this is a general view of our brain-informed study. So we are doing this functional assessment of the corticospinal tract, looking specifically at different brain muscle connectivity profiles. We're doing a functional assessment of the corticospinal tract and other parameters. And we are specifically looking at these different subcomponents of the upper limb motor deficit that we talked about, the hand strength and dexterity, the proximal reaching dexterity and the proximal strength, etc. And we are having people whose therapies are informed about the information their functional corticospinal tract integrity, and just the conventional therapy group. And we, will know the results hopefully at some time, but right now it's an ongoing thing. So this is how how it looks like. This is a non-invasive thing, but we can look at concrete brain of a person, stimulate in different parts. Maybe you'll already recognize in this hand knob area. So we stimulate in different areas, and we are measuring responses in different muscles, in many, many muscles. And then we provide this information to therapists. So we are building a visualization for that, and we are trying to compare. So the red is the behavior, like what a patient is able to do, and blue is a result of our brain muscle connectivity. We're trying to overlay them to see how we can use one to push the other. And we already, we are talking to therapists. We started talking to therapists in Finland. We're also talking now wider in the world, in Ireland, in the UK and US, and getting therapist feedback. And it looks like therapists believe that it may be very valuable as well. So occupational therapist and physical therapist thinking that may use this information to change or to update their clinical reasoning. Then let's just very, very briefly touch the questions, because we got the questions from the audience, which were not exactly about the upper limb motor deficit, and they definitely will need a separate conversation if we want to talk about it. But there were quite a lot of questions about the balance, and what I can say immediately is that, hemiparesis, the problem with the upper limb, is a separate thing, but at the same time, it's also very much connected then with the balance. So if the body is not symmetrical, definitely the balance also would be affected, even if there is no separate problem with the balance, which can be if there is for example, cerebellar problem, not the motor cortex, but cerebellar and others. So it's very important, and there are proofs of that the balance exercises and vestibular exercises, they are classical, there are standard exercises you can see in the internet, balance exercises, vestibular exercises, they do work if you do them. And they do work also in chronic periods. So there are proofs of that. And there are also, there are proofs. I'm not a specialist in the balance, so you really need to talk to the to the physical therapist about that. But there are approaches which are called dual task training, and it's very widely used for different purposes. But it's just when you're training something motor, let's say you're training a balance, you're staying on one foot. And at the same time, you are making yourself a bit distracted. It would be great if somebody's helping you. You are asking simple questions, you are counting back, you are remembering the birthdays of your family or whatever. And you are getting yourself distracted and at the same time trying to do the balance exercise. So those are really good ones, and you can try them when they are safe. You should be safe when it's a balance problem for sure. And one important thing is also that dizziness and balance are not always caused by stroke. Say, or we can have sometimes worsening or sudden dizziness that will really need medical attention. So that's something to have in mind. And there are lots of peripheral problems with the inner ear, which can lead to dizziness. So, and then the ENT doctors can help with them much better than neurologists. So that's something to have in mind. And just take-home messages about the upper limb. So first, stroke is common. So apart from the fact that, it's really a lot of suffering for many people, kind of a silver lining of it is that you're not alone. It's definitely something that you can find in, in the district, or you are living, there would be other people with stroke. So there are lots of people with stroke. We just need to work on the community, but there are many, many people with stroke. Then arm and hand recovery and arm and hand deficit is very complex. So we have these different dexterity strands or problem with the tonus, etc. And we need to think, what do you train today? So you should think about the problem of their arm and hand, not just like problematic hand, but let's say that you are trying to achieve the goal reaching. And in this case, you need this anti-graft support. That's as an easy example. Then learn non-use, not using even those capabilities we have is extremely common. We don't pay attention to that as much as we need to. So that's worth reminding, worth training. And like if there is a chance to constrain the healthy, unaffected hand, it may be a good idea to discuss it with the physical therapist. Active treatment does pay off. So, I mean, that's maybe like really the key thing, is that in the chronic phase, conventional small level of therapy was not shown to be working, but active treatment was shown, proven to be efficient. So it's just important to have in mind that you really need to have this kind of, like if you want to get better, you need very, very active training. And then big thing to have in mind is that research is moving forward. So there are lots of studies about this reopening of the sensitive period, drug therapy, different type of therapies. And we are ourselves working on finding the way to implement the hidden brain potential running the study, Brain-Informed. So we really hope that we also bring it to a next step. So thank you very much for your attention, and we have a fantastic team and great medical advisors, and yeah, I think that if there are questions, it would I'm pretty sure that they can be sent. We'll be happy to answer.